Well, hello, everyone. On behalf of the American College of Cardiology and the Center for Systems Improvement, we'd like to welcome you to this module in the EMS and Systems of Care webinar series, Taking Clinical Quality to the Next Level. This is the 8th webinar of this series, and it will explore some ideas about EMS STEMI Alerts and improving their accuracy. One of the moderators for today's session is the one and only Tim Phalen. I've known Tim for about 20 years. I think he's probably one of the nicest people I've met since I've become a professional paramedic. You probably all know Tim or have been in one of his ECG classes because he really is a master of STEMI recognition. And he's just adored by children throughout the land. I believe they follow him around and bring him snacks. So thanks for being here, Tim.
Well, thank you for that. I just want to make it clear, while I may be adored by children, I do not have a white van. Okay. And and again, I'm going to say the same thing for Tom. I think everybody knows Tom. I think you knew him before these series started. If you've plugged into any of these, you've seen him as well. And he's one of those folks who just gets 3 lifetimes worth of stuff done and just keeps going. So he's the battalion chief for EMS at Hilton Head Island Fire Rescue. And he is super involved not only with STEMI, and he started EMS 12 lead, gosh, I don't even know how long ago, and grew that. And he's, in addition to everything else he's doing, he's very, very plugged into cardiac arrest and improvements there. He's the program director for the South Carolina Resuscitation Academy, and it's his high performance CPR working group. And if you don't know him from all that, you may remember him from his days as a Calvin Klein underwear model. So and we are all getting together here and looking forward to this.
Before we begin, you should know that part of the webinar is recorded on video, which will appear in the pop-up window. If you experience problems seeing the video, you may need to disable the pop-up blocker in your web browser. If you're watching this live, at any time, please feel free to enter any questions or comments you might have into the question box in GoToWebinar control panel.
So to do that, in your control panel, look for the questions tab and you click on it and it should open up a section. And that section will then allow you to enter your question there in the space provided. And what we're going to do is this particular one is a little bit shorter than usual, not that there's a lack of content, but we're going to have a panel discussion and we really want to hear from you guys. So we're going to try to make this much more of a dialogue, or at least to the extent that we can. So please take advantage of that opportunity. And as time permits, we'll do all of the questions that we're able to.
If you're watching the archive recording of this webinar, please feel free to send any questions or comments directly to Mick, that's MIC, at improvethesystem.com. The archive recording will be posted soon after the live session with an email notice and viewing link sent out to everyone who registered for this event. Mick will do his best to respond to questions and comments sent in by email, regardless of how long it is after the live event that you might be watching this.
All right, we're getting ready here. So Mic Gunderson is clearly somebody you're familiar with, if not before these series. I don't know how you could have missed him. So I have also known Mick for many, many years. We were both from Florida and we bumped into each other in the early EMS days. And here's what I can tell you. If there is a brain drain in EMS, I'm really glad we didn't lose Mick, okay? He is truly just one of the most brilliant people that I've ever met, but he just has this sense of not only how to take content and information, but to just kind of, where the rubber meets the road, kind of actually bring change. So he has devoted most of his EMS career in one way, shape, or form to quality management, okay? And so he's the president at the Center for Systems Improvement, and they specialize in elevating the performance of community and regional systems of care, particularly, high risk, time-sensitive conditions, no pressure, as well as he does EMS assessments and quality improvement training, and he's just all over the place. So, and he's currently working with the American College of Cardiology in the development of EMS systems of care, and this is part of the whole process here. So let me turn this over to Mick now. We'll get started.
Well, thanks, guys. I appreciate you both being part of today's presentation. And I'm particularly happy you're both here. As mentioned earlier, we'll be doing a bit more than moderating in today's session. We're going to be talking about STEMI recognition, and that's obviously something that you both are true subject matter experts on with STEMI Alerts and given your extensive teaching and consulting activities in the area. So our discussion with Tim and Tom on EMS STEMI Alerts will come right after the video portion of the presentation. So without any further delay, let's get started on that. And there's going to be a brief pause while the video segment loads up to appear on your screen. This EMS and Systems of Care webinar series is brought to you by the American College of Cardiology's National Cardiovascular Data Registry, the NCDR. They're the stewards of the Chest Pain MI Registry and its new reporting tool, NCDR eReports EMS. This tool generates STEMI and NSTEMI reports that are specific to your EMS agency, EMS system, or regional system of care using the data that's already been entered by your receiving hospitals. For more information, check it out at acc.org/eReportsEMS. If you'd like to watch any of the prior webinars from this series in their entirety, descriptions and links are available. Just scroll down to the resources section of the page. Many EMS agencies have formal policies for declaring EMS STEMI alerts, and they're generally modeled on the time-tested processes for EMS declaration of trauma alerts. And this is great. Just like trauma alerts, STEMI alerts can have lots of benefits when used appropriately. And the most important of those benefits is saving time. The sooner a likely STEMI can be identified in the field, the sooner the hospital is given an EMS STEMI alert declaration, the sooner the hospital can start to prepare for patient arrival by activating the cath lab. If the EMS STEMI alert comes in during normally scheduled cath lab hours, the lab may delay or reschedule a patient about to get on the table with an elective or less urgent problem. This would allow the very time-sensitive potential STEMI case on its way in to take priority. If the cath lab is already in the middle of a case, they may try to finish up, but with a bit more hustle to get ready for the incoming emergency case. Or it may be that the STEMI alert is coming in when the cath lab isn't staffed. This is commonly the case during the evenings or on weekends and holidays. In those scenarios, the cath lab team members on call will be notified to come in and the lab itself will need to be set up. And obviously, all of that will take some time. The ideal scenario is to have all the members of the cath lab team in place and the lab completely ready to go by the time the patient arrives at the hospital. That is more likely to happen the sooner that the EMS agency notifies the hospital of the STEMI alert. EMS STEMI alerts initiated appropriately and in a timely manner allows the patient to get into the cath lab and have their obstructed coronary artery reopened sooner than later. When EMS delays declaration of the alert, the potential time savings are squandered. And time is important because the amount of myocardial muscle tissue that gets injured or dies increases as the total myocardial ischemia time increases. And the more tissue damage we have, the greater the chances of long-term heart failure issues, and the greater the chances for short-term risks of complications, including dysrhythmias and sudden cardiac arrest. The best measurement we have of total myocardial ischemia time is from the time of acute onset of symptoms until the obstructed coronary artery is successfully reopened by a thrombolytic drug, coronary artery bypass surgery, or most commonly with a stent that's placed in the cardiac cath lab. There are some time targets out there for getting the patient's coronary artery opened within 90 or 120 minutes from EMS first medical contact, depending on the circumstances. But that does not mean that there isn't significant benefit in getting the obstructed coronary artery opened sooner than that. The sooner the artery is opened, the better the outcome is likely to be. Now, several times I've mentioned appropriate use of EMS STEMI alerts, and that merits some discussion. We'll initially focus on this from a quality improvement and process design standpoint. A clinical process design is written out as a protocol or policy. So the process design issues that I'm about to discuss are generally true for other protocols as well. and we'll talk about this in more detail from a clinical perspective, more specific to STEMI care when we get to the discussion portion of today's webinar with our moderators. First, crews need to follow their protocols. EMS STEMI alert protocols should clearly identify what criteria need to be met or considered in making the decision on declaring or not declaring a STEMI alert from the field. It's going to be very difficult to know how well the EMS STEMI alert protocol or process design is performing if the protocols are not even being followed. After all, of what good is the protocol or the efforts to make improvements to the protocol if it isn't being followed? Granted, if there are unusual circumstances or other factors that compel the field clinician to vary from the EMS STEMI alert protocol, that's fine. But those unusual circumstances or factors should be mentioned when making or withholding the alert and documented in the EMS patient care report. That sort of information should be flagged for review by the EMS quality manager and the medical director, not so much because the protocol was violated, but because the unusual circumstances may present an opportunity to refine or improve the protocol. Think of it this way. If another crew encountered those same factors or circumstances again, how would you want them to respond? Instead of leaving it to chance how different crews with different experience levels and expertise will each react, it may be worth having some conversations between the crew involved, the quality manager, the EMS medical director, and even the cardiologist in some cases, to take advantage of the collective expertise of that group to help guide everyone to the most appropriate decisions should those factors or circumstances happen again. This is one of the big advantages of case reviews. We can all learn from those unusual cases, and we can consider making adjustments to our process design, our protocols, to improve the chances for good decisions and outcomes in the future. Second, the EMS STEMI alerts need to be made as soon as the necessary information is available. STEMI alerts are of minimal value when the field crews knew at the scene that a case met STEMI alert criteria but didn't declare the alert to the destination hospital until the ambulance was just about to arrive. And even with short transport times, notifying as soon as possible from the scene can give the hospital precious extra minutes to prepare. Third, don't game the system. In context of EMS STEMI alerts, gaming the system occurs when an EMS clinician or organization intentionally changes or biases their decision-making process to favor their performance statistics or reputation or ego, rather than just making their best assessment of the patient and their best decision on EMS STEMI alerts in good faith. And we'll tend to see gaming happen more often when there's problematic issues in the feedback. This can manifest in a couple different ways. Individual EMS clinicians may hold off on declaring an EMS STEMI alert because they were inappropriately criticized at the hospital or by their own EMS quality management process for calling a STEMI alert, and it later turns out that the patient did not have a STEMI. And there's an important difference here between constructive feedback and inappropriate criticism. Constructive feedback will usually involve talking about the case in private to point out some nuances on the ECG or patient presentation that the field clinician might take into consideration next time. And this is dramatically influenced by the tone, demeanor, and intent of the person giving the feedback. The tone should be positive and educational. The premise should be that the crew acted in good faith. There's a legitimate opportunity to learn here. We want to promote a learning culture. The person providing feedback needs to use the right tone and demeanor. The EMS clinician needs to accept the feedback with an open mind and a willingness to learn and accept constructive feedback in the right spirit. For this to happen, trust needs to be developed over time between both parties. Inappropriate criticism has a harsher tone. It can be accusational, demeaning, and unprofessional regardless of the technical issues being pointed out. When this happens at an individual level, it is often done in such a way as to embarrass the EMS clinician, like out in front of the rest of the ED staff or in front of the patient. At an organizational level, it might happen in meetings. The EMS director or quality manager might get chastised by the emergency department leadership or the cardiologists. The same issues of tone and demeanor apply here as well. But the real damage from inappropriate criticism occurs at several levels. It can do severe damage to the trust I just mentioned a moment ago for constructive feedback and learning to be accepted in the right spirit. It will also tend to discourage crews from declaring alerts in the future. The crews may tend to let the emergency department decide rather than risk getting chastised again. At an organizational level, it may show up as a reluctance not to put a formal EMS STEMI alert protocol or policies in place. If crews do not have a process to formally declare EMS STEMI alerts, the EMS director may feel that their organization and their crews are less likely to be inappropriately criticized. Nobody, not even the ED physicians and cardiologists, get it right every time. There will be some cases where the ECG and patient presentation all pointed to STEMI, but it still turns out not to be the case. These are sometimes referred to as overcalls, over-triages, or false positives. There will be other cases where EMS did not pick up on something or did not feel strongly enough that it was a STEMI, so they did not call an alert. Those missed opportunities for saving time are called undercalls, under-triages, or false negatives. Both overcalls and undercalls can happen in good faith. The key is knowing when it happens and then trying our best to learn what might have been done a bit differently next time. It may be an opportunity to learn about a particular STEMI imposter or some other clue in the patient presentation that can help make the EMS clinician just a little bit better in picking up on that clue with future cases. We might also see gaming tend to occur more often when there isn't some good balance in how the performance of the EMS STEMI alert process is being measured. If an individual or organization is tending to shy away from declaring EMS STEMI alerts, there will be fewer overcalls, but there will be more undercalls. Taken to the extreme, if an EMS clinician or organization never commits to a decision on giving a STEMI alert, they will have 0 overcalls, but all of the actual STEMIs will all end up as undercalls. This can happen pretty easily if the EMS undercall rate is not being measured. We could also swing to the opposite extreme. We could drive the undercall rate towards 0 by calling a STEMI alert on most every patient. That way you'll know that every STEMI patient got an EMS STEMI alert, but the overcall rate skyrockets. Neither of these extremes are desired. Both can cause harm. What we want is an appropriate balance between the two. We do not want the threshold or criteria for declaring an EMS STEMI alert to be so stringent that we end up with a lot of undercalls, because undercalls are the most dangerous. Those are the missed opportunities to save time, save muscle, and save lives. But calling EMS STEMI alerts too liberally can cause unnecessary fatigue in the process. Cardiac cath lab team members may lose some of the hustle they might once have had in coming in for the EMS STEMI alerts if most all of them end up being false positives and they end up getting canceled most of the time anyway. This also creates a huge waste of time, resources, and money for the hospitals. More dangerously, it can also tie up the cath lab from accepting another inbound STEMI patient, causing a diversion to another hospital further away, and thereby wasting more time and creating more risk of harm. We want to have the EMS STEMI alert criteria and judgment of the EMS clinicians to be just liberal enough to keep the undercalls to a minimum, but not so stringent that cases are being missed. So how do you find that balance? The effort to find the right balance begins with measurement. Find your current level of performance, your baseline. Measure your overcall and undercall rates as the process currently operates. You might compare your overcall and undercall rates with what's seen in the literature as best practices. You can also compare your rates by talking to your colleagues in other systems. But one of the problems is that many of these STEMI alert accuracy studies in the literature and other EMS systems in your area may not define overcall and undercall cases in the same way. So in 2019, the PREACT paper was published. It was written by the American Heart Association's Mission Lifeline program. One of the things this paper did was offer a standard definition for both overcalls and undercalls. An EMS overcall was defined as a case in which an EMS STEMI alert was declared, but the patient did not receive an emergency angiogram and did not end up with a myocardial infarction diagnosis. Some refer to this as activation without intervention. Undercalls were defined as cases that had a diagnosis of STEMI, got an emergency angiogram, but did not have an EMS STEMI alert. There are some additional details to these definitions, but this gives you a general idea of how they tried to standardize the overcall and undercall terminology. The full paper with all of the details can be accessed and downloaded for free at the web address on the screen. This web address is also available in the handout section of the webinar platform as well for those watching this live. Once you have a baseline on what your organization's overcall and undercall rates are, you can see if your overcall rate seems to be too high compared to similar EMS systems. If they seem too high, there's a couple things to try. Look at your overcalls in detail. Were there commonalities between them? Maybe a lot of them were so-called STEMI imposters, things like left ventricular hypertrophy, left bundle branch block, pericarditis, and patients with pacemakers. These patients can have ST elevation without having an acute coronary event taking place. Your improvement hypothesis may be that delivering additional training for the entire agency on those STEMI imposters will help crews better differentiate them from true STEMI patients. You might have an improvement hypothesis that transmitting the ECGs to the receiving hospital will reduce overcall rates. I would emphasize getting a baseline, though, on your overcall and undercall rates before making this change. That way you can see if it actually made a difference for better or worse, or it might not make much of a change at all. Some of the best EMS systems in STEMI care do not transmit, some of them do. You need to measure to determine what impact the transmission policy change actually had on the accuracy of your EMS STEMI alert process. Another improvement hypothesis could be making a change in the criteria used in your STEMI alert process. You might try making a small change to make the criteria a bit more stringent, maybe a bit more ST elevation, maybe a tighter age bracket. There are several options here. See if the overcall rate goes down after making those changes, but without making a significant increase in the undercall rate. If the overcall rate goes down and the undercall rate remains stable, consider making some additional small incremental changes until you see the undercall rate just start to bump up, and then back up to the prior incremental change before the undercall rate ticked up. But with this approach, you need to carefully monitor the overcall and undercall data to guide your efforts. Ideally, I'd love to see a research study that takes this incremental change approach to EMS STEMI alert criteria and see how the overcall and undercall rates respond. The ideal study in my mind would have a very large number of cases from a diverse population of EMS agencies with a wide range of total ischemia times. More detailed data would be collected during the study period so the changes in the criteria could be applied afterwards, retrospectively, to see what combination of criteria would have yielded the lowest undercall rates while keeping overcalls to a minimum. A study like that would really help us find that sweet spot in balancing the overcalls and undercalls. The trauma community has found a balance for this in trauma alerts. It would be wonderful to see this for STEMI alerts. So now let's bring our moderators into this discussion, Tim Phalen and Tom Bouthillet. Both of them have a lot of expertise in this topic area, working with a wide variety of EMS agencies around the country.
All right. Excellent work as always, Mick. And here before we jump into the discussion, I'll just throw this out. As a dinosaur who's been around forever, been involved with the STEMI stuff since before the name STEMI existed, one of the things I try to really stress right now is it's just too early to declare victory. I mean, truly, we have come so far in recognition and management and pre-hospital activation of STEMI. And I think sometimes we just kind of get complacent and we just say, hey, we're doing okay. And we're doing infinitely better than we used to. But as you identified, kind of the simultaneous goals are how to simultaneously increase correct recognition and how to not eliminate, but reduce inappropriate activation or overcall. So why don't we jump in with some questions?
Let me start out with one question. And again, I'm going to treat this more like a panel discussion versus our usual format. But again, given the subject matter expertise that you both have, I'd like to get your impressions about what you've commonly seen as the causes for the EMS STEMI alert overcalls. Something in EKG interpretations that seems to come up a lot, or maybe something else. What are your thoughts about that, Tim?
Well, there's many. Alrighty. So this broad brush here is one of the things that's going to do both. Reduce inappropriate activation and increase correct activation is getting a quality ECG, a clear ECG, steady baseline, free of artifact, electrodes in the right place. There's no sex appeal to it, but that's just the foundation of everything. If this was a football team, before you get into, what kind of exotic offenses you're going to be running and what kind of defensive, coverage you're going to have, you just got to make sure your team can block and tackle. And if you don't, you're not going to win a lot of games. And in the STEMI world, that's just the beginning. That's the blocking and tackling. You got to start with a clean ECG. So having said that, in terms of reducing overcall, probably two things. One would be learning to how to integrate the interpretive statement. I've kind of morphed over time. I used to be, no way, man, this is like, it's our job. I don't want to hear from the man in the box. I'm the interpreter here. And I've kind of evolved to a pattern of, okay, I'm still absolutely the primary interpreter, but I want to figure out what the machine does well. And if there's some things the machine does well, I will incorporate that into my critical thinking. But having said that, if that machine says STEMI, it's much more difficult for a paramedic to say, I just don't really agree with that. They just kind of feel the pressure. So clean ECGs, the device calling it a STEMI when maybe you wouldn't have, and you just kind of feel a little hesitant to do that. But then the other broad category is just the STEMI imposters, the non-ischemic cause of ST elevation. There's a whole bunch of them. There's more than 20. They're common. In one report, 85% of all cases of ST elevation in the University of Virginia Emergency Department, in that little sample, 85% of those ST elevation cases were an imposter, 15% were STEMI. So there's a lot of them. You're going to run into them a bunch, and they produce a pattern that looks a lot like STEMI. So we don't have to be junior cardiologists, but a simple heuristic plan that just helps people manage those things with an approach that gets you pretty far at 2 o'clock in the morning at the end of a double shift. I mean, those are the things. And if I was to throw one more out there, it would probably be, there's a lot of technology that's out there, but it's not really utilized to just have a real-time consult. Not on the ones that we should. We should get the yeses and we should get the nos. But if you're smart enough, intelligent enough, sophisticated enough to correctly identify a complex ECG, it'd be really great sometimes on those cases to be able to have a conversation and to talk to somebody about that. So, I mean, that's kind of the icing on the cake. But I'll shut up now and let Tom give us his perspective on this.
Well, I'm not going to disagree with anything that Tim just said. I agree with all of it. So the importance of the data quality of the ECG really can't be overemphasized. So in my system, we require two things before you're able to call a STEMI alert from the field. Number one is that you've obtained an ECG with excellent data quality. And then number two is we ask for clinical correlation. So I think where paramedics sometimes get into trouble is they take a patient with very low pretest probability. So it's 3 a.m, your chief complaint, you have an elderly female, the complaint is general weakness. Is it possible that this is a STEMI? Sure, it's possible, but the pretest probability isn't that high. She may have sepsis or something like that. But you get a 12-lead ECG because you're supposed to, because it's general weakness, and then it has poor data quality, and that poor data quality trips the interpretive statement to stay STEMI. And so Tim said, that paramedic doesn't want to be wrong, so he errs on the side of calling the STEMI alert. And then maybe they transmit this ECG with poor data quality to the emergency department. All of that kind of degrades the trust that the hospital is going to place in us before they call in a consultant at 3 o'clock, Sunday morning. So it's really important that we get an ECG with excellent data quality. And what we like to say is when the pretest probability is high, so you have someone that is having classical chest discomfort, they're diaphoretic, they've got left arm pain, and they're nauseated, and they look like a picture of shock, the pretest probability is high. So we would take even subtle ECG abnormalities more seriously in that scenario. But when the pretest probability is low, then we would really need a compelling ECG for us to call a STEMI alert in the middle of the night. So that's my comment on that.
No, that makes an awful lot of sense, Tom. But given the importance you're both placing on the importance of the quality of the ECG, being the quality guy and trying to jump to a root cause analysis, what are you seeing as common causes for the data quality issues? Is it the diaphoretic patient with poor electrode adhesion? And if so, what are your recommendations on how to combat that? I remember, when I worked in the field years ago, we had some stuff that we could, kind of put on the skin and it would make the electrodes adhere more. More recently, I've even seen in exercise physiology and stress test labs, they've got something that almost looks like a Black & Decker drill that does a little bit of skin abrasion in conjunction with putting on the electrode. So what might be some critical success factors, if you will, to getting good, clean baselines on the ECG?
Can I take a stab at this one, Tom?
Absolutely.
All right. So I don't want to cut your opinion out, but so before we started today, I was creating an animation that just kind of deals with this very topic. So if if we were at the pub over a beer, I could draw it on a napkin. So you got to kind of use your imagination here. But the number one issue with Artifact is the electrode patient interface. Now you're doing a 12-lead ECG, so the frequency response is such that the device is more sensitive to the heart's electrical signal. Good, but that also makes it more sensitive to the causes of Artifact. That's our problem. So the very time we need the ECG to be the clearest is literally the time when it's most likely to have Artifact. So the first lowest hanging fruit, help that electrode gel to penetrate. So sticking is an issue, of course, but even if the electrode sticks well, you have to get the gel through that layer of dead cells, the stratum corneum, kind of through the stratum lucidarm down to the stratum granulosum. And like way back when, I was so bored at the station, I read the instructions in my electrode box. Yeah, that's how bored I was. And here's what it said. It said, apply the electrode 30 minutes before intended use. That freaked me out. So I called the company. This is back when you had to pay for long distance calls. And that's when I learned all this. And they said, yeah, we can't get people to prep the skin, because if you prep the skin, you eliminate a bunch of those dead cells. When you slap the electrode on, more of the gel is able to get down to the level where you can pick up the heart's electrical signal and reduce the causes of Artifact. And so since people were resistant to doing a skin prep, like taking an alcohol prep on a 4x4 with a brisk rub, even that much, the workaround was to apply the electrode 30 minutes before intended use so it would have time to soak through. Obviously, that doesn't work in all worlds. So it's kind of a long-winded answer, Mick, is that nobody wants to hear it, but you start with a decent quality, fresh electrode. Don't pre-snap it to the cables. Don't have it in the electrode bag that was open 3 days ago. Take an alcohol prep, quick brisk rub, follow it up with a washcloth or a 4x4. It's not stress lab quality prep, but the difference is often night and day. Now, there's still patient movement, and there's other things as well, but for sake of time, I would say that would be our maximal return for least investment.
Sounds good. Makes sense. Kind of gets back to that thing I've observed in the stress labs with the pre-abrasion of the skin to kind of make sure we're getting to the right layer of the skin. Anything to add to that, Tom?
I'm a big fan of doing it right the first time, and I think when we take shortcuts, if you have somebody that has a lot of chest hair and they're really diaphoretic, and you're like, okay, well, this is STEMI, so this needs to be done really quickly, so I'm just going to put these electrodes on top of the hair and just mash down with my fingers, you're going to be having difficulty throughout the entire call. The electrodes are going to be falling off. You're not going to get a high-quality tracing, and you personally are going to be stressed out for the duration of the call, and there's less likelihood they're going to activate the cardiac cath lab. So I always felt like doing it right the first time, like getting your clippers out, shaving the chest. I'm with you, Mick. I like tincture of benzoin. I've heard people caution that it's flammable. There's anecdotal case reports of people defibrillating over tincture of benzoin and burning the patient and things like that. Okay, don't defibrillate over it. But if you shave that spot where V1 and V2 and V3 go, and you put some tincture of benzoin, and then you just hold the electrode down for a couple extra seconds, those electrodes are going to go on. They're going to be perfectly placed. And when I have done that to a patient that has challenges, especially with their precordial leads, when I come into the emergency department, the nurse takes a look at it and says, oh yeah, I'm going to use those electrodes, and they just put their alligator clips right on it. So, and now you've got a baseline for comparison. You know the electrodes are in the same spot, so you can compare one ECG to the next. I would just say sometimes you have to slow down to go faster.
Sage advice, and I'm glad you mentioned the tincture of benzoin. I was grasping at what the name of that stuff was, so thank you for that. So, we might end up with scenarios from what you guys have both describing where if this seems to be something that in general seems to happen with the agency with poor electrode preparation, let's call it, and maybe some issues with the continuing education or their initial training, particularly with the STEMI imposters, those might be root causes you could look for if the agency has a lot of undercalls. So let's move on a little bit though. And I made reference to trying to get an idea of what your agency's rates on overcalls or undercalls were compared to others. And again, based on your observations going around the country, what sort of overcall rates do you tend to see in EMS agencies that have pretty good working STEMI systems of care? And how are they defining their overcalls? Or is there not so much explicit overcall and undercall measurement, and it just seems to be based on how often they get some subjective feedback from the interventional cardiologist or the receiving hospital about turns out that one wasn't a STEMI, or later on we discovered this one did have a STEMI, but we didn't have an alert. Just trying to get a sense of what those numbers might look like and what those definitions tend to be out there in the real world. What are you seeing out there, Tom?
Well, the first thing I'd like to say is that a undercall, quote unquote, can happen at any level in a STEMI system. That can happen pre-hospital, that can happen in the emergency department, and yes, it can happen with the consultant that's called in. Any of them can make an undercall. So, and it could be all three. So there's sometimes in post-event review, I'll be putting eyes on ECGs that were taken in the field, and I'll go, oh wow, look at that. A true acute isolated posterior STEMI. And then I'll look in, I'll pull the chart and I'll be like, ooh, my paramedic kind of missed that. But then we'll check in with the hospital. It's like, oh, well, the emergency physician missed that. Oh, wait, the cardiologist missed that too. Patient cathed the next day, they find an occluded circumflex and they call it non-ST elevation myocardial infarction. So all of us can undercall. And then it begs the question, do our systems of care have an accountability problem? I wonder that sometimes. So I think number one is I wish we could change the paradigm to starting with occluded arteries in the cath lab and working our way backwards through the STEMI system to see how it performs. I think we've taken prospective analysis of how we perform as far as we can take it. What do you think, Tim?
Well, pretty much lining up with you. I'd say undercall is a real thing for sure, and isolated posterior STEMI is a classic example. So I'll kind of reflect back to what you're saying but just so I don't forget, is that probably what I've seemed, my belief anyway, is that the number one cause of undercall, missed opportunity, is just lack of a perception of how truly dynamic STEMI can be. And we think too often in terms of let's get a 12 lead, take a snapshot rather than make a movie. So one study just did this. They said if you do serial ECGs pre-hospital, and it was a big number, it was like over 400 STEMIs were in this, that 15% of all true STEMIs did not have ST elevation on the initial 12 lead ECG, but it did occur either later on scene or around. So from a procedural issue, just acknowledging that and writing our protocols accordingly for serial ECGs, ST segment monitoring. I'm always big on the lowest hanging fruit. That's kind of some low hanging fruit. Then the other issue is, gosh, we just got to get our vocabulary straight. Mick's original questions, what are the numbers? I've almost stopped asking. It's just because it's almost impossible to compare apples to apples. I mean, I was with a system recently, and they were very, very proud that they had a 2% false positive rate. And I'm just like, cardiologists don't have a 2% false positive. So obviously how they're defining it is got to be so tight and so narrow that I'm just not even sure. So there's false positive, there's overcall, and then there's inappropriate. And I guess ultimately what I come down to is that looking at the evidence at hand, given the information available, was it appropriate to make a STEMI activation? That's what I try to coach for. And if later it turns out to be Prince metals, so be it. Okay, that's you still did it appropriately. But yes, as Tom was saying, is that we really, really need to tie it in, because it can be confusing, because what goes down in the books as a false positive in the hospital, it's kind of a cardiology distinction. Here's a quick little scenario. So you get that, let's go back to Prince metals. It's functionally as a STEMI if the spasm persisted, but there's no occlusion. So that would sort of go in the false positive category. Versus some patient who's just got a bunch of things wrong with them and they just got a really nasty ECG and the paramedic just goes, I don't like it. And they just take them to the cath lab. And they do a STEMI alert. And it's like, yeah, well, it's not really. But hey, while we're here, we're going to clean some stuff up. And that may not go down as a false positive. So it was just the complete converse. The one that was absolutely appropriate may go on the books as a false positive. And the one that wasn't appropriate, they did something while they were there. So potentially that wouldn't go as a false positive. So all that is to say, I don't know if this is more your guys' world than mine, but I remember when cardiac arrest was new and nobody was comparing apples to apples, and they had that meeting at Utstein and they sort of came up with a standardized approach. And I think in many ways that's kind of the next step for us is to get a standardized set of definitions, and then to do that in such a way as to be able to provide the most meaningful, the most helpful, the most actionable feedback to EMS.
Yeah, no, that makes a lot of sense, Tim. And that was one of the things I liked about the PREACT project, was they were trying to at least try to get the ball rolling towards the standardized definitions. And as you're aware, there's been other things in the literature trying to offer standardized definitions as well, but they didn't get a lot of traction. So I still think that we've got some work to do there. But we've got about 15 minutes left here. Let's go to questions from the audience. Do you guys see anything in the queue?
One of the questions is, what is an acceptable overcall rate? And I think to Tim's point, first you have to agree on a set of facts and a set of definitions, because the devil's in the details. And if it's an overcall because it was canceled by the ED physician, that's one thing. If it is an overcall because there was no clear culprit artery, that's another thing. And that's imperfect as well, because the cath isn't everything. You could have a spontaneously aborted MI. You could have stress cardiomyopathy or focal myocarditis. And I agree with Tim, those are all appropriate cath lab activations. And so that's where I think you get back to, like, we need a standardized template. And it would be really, really interesting if all of these cath registries out there can be utilized in a way to where we can start to make the STEMI, non-STEMI distinction kind of blur a little bit, and start looking at which arteries are occluded and which arteries are not occluded, because we all know that, if you have classical symptoms and you meet criteria, you're probably going to go to the cath lab quickly. So everyone out there should hope when they have their heart attack and they have their occluded artery that they meet criteria, okay? I worry about the people that don't, but they're still losing myocardium, and I don't think we've done our best. So I think, Tim, earlier you said we shouldn't get complacent. And if there's one thing I have learned from the Seattle King County Resuscitation Academy, it's that you should always be improving. You should never assume you're operating at the best possible level that you can operate. And so if we're going to be a learning culture, I wonder sometimes why we don't have honest conversations about those patients that don't go to the cath lab in a timely manner. And we know from their rise and fall of their troponins and their post-cath echo that they've lost too much myocardium. We'll know we've arrived at a true learning culture when we have frank conversations about that.
No, interesting points, and that gets back to some of the cultural issues that I was trying to make reference to in the video about basically is there trust and confidence in the system so that you can have those candid conversations and you're not gaming the system either by the cardiologist calling that an NSTEMI when it was really a missed STEMI, and a lot of those sort of things that tend to creep in kind of under the radar and distort the statistics sometimes.
I'll go ahead and throw in, I'm not unsympathetic, okay? I understand that they have a very difficult job, and it's very easy to criticize with the benefit of hindsight and the retroscope. I also think that this getting feedback from the hospital thing, and there's health data exchanges now, and we get feedback after the case. It's still kind of early in this whole getting feedback from the hospital thing. And so it's still kind of paternalistic, like we'll give feedback to you, but when that feedback is reversed, the hospital receiving feedback from the EMS system, I think if the hospital says to an EMS system, you guys missed a STEMI, that sounds like an opportunity for improvement. If the EMS system says to the hospital, you missed a STEMI, that sounds like an accusation of malpractice. So there's this whole medical legal aspect that makes it complicated. I do have sympathy there. But if we're going to be a learning culture and we're all putting the patient's needs first and foremost, we ought to be able to take a 360 view of how the system's performing.
Indeed. And
well said, Tom.
Yeah.
Well said.
Our just culture needs to extend not just within the walls of the EMS agency, but to the system of care.
Exactly.
Hey, Mick, got a question here for you. So I'll just kind of summarize. They liked your thought there of sort of titrating the STEMI activations because you're measuring your rates of overcall and undercall, and you're kind of tweaking it based on the evidence. And their question was, what if you have a small to an average size service? How do you overcome sample size? How do you just manage that reality and still go forward with your recommendation?
Yeah, and this is why I made the pitch for the research study, because I was actually thinking about that scenario as I was putting together that presentation, is the amount of time it would take to get large enough case volume to have a good idea of what your true overcall and undercall rates are as a reflection of your process design. Other factors in the system are likely changing at the same time. So that makes it really difficult. And that's one of the reasons why I was trying to gauge your impressions about where those numbers currently are. But the lack of a uniform definition is really the big barrier to that. But if we could come up with a standard definition and then enroll multiple EMS agencies to get the big enough N with the diversity of agency types, total ischemia times, implicit in that is diversity of transport times, and then see, what sort of criteria are necessary to reach that appropriate balance point between the overcalls and the undercalls, as I alluded to. But yeah, in a small volume or even moderate volume system, that's going to be really, really difficult, and that's the role I would see a multi-institutional research study playing. So if any of you listening to this webinar are researchers and looking for a potential topic to chew in on, that would be at the top of my list today.
Yeah, that is huge. That is huge. Well, we've gotten several questions, so I'll handle this one, and Tom, I'll let you take a peek, and you can read some of the other ones here. This one is pretty straightforward. It's Zakiya, and the first question was about the common causes of artifact and how do you individually address them. And then there was a follow-up. There was really a statement that they have a few ideas on how to fix this and just want to know how to reach out to manufacturers. And I think it'd be as simple as just asking for the clinical folks. Whatever manufacturers you wanted to talk to, invariably they have a clinical department, And that would probably be a great place to start. And they speak your language, and you could initiate the conversation there and see where it goes as a result.
One other thing I would add to that is I know a lot of industry representatives, particularly in the cardiovascular arena, folks from Zoll and Physio, et cetera, Philips, participate in a lot of these EMS discussion groups, like the NEMSMA listserv. And so having conversations in those sorts of, more public venues about those issues and potential solutions can catch some appropriate attention from the right people, as well as even considering writing an article for, EMS One, GEMS, EMS World, whatever the case may be, about the issue. And that will certainly get their attention because they do monitor the literature pretty closely on those sorts of issues. So a couple other suggestions there.
So here's an interesting comment from the questions here. Mike Larson comments, I work in a hospital, and the way we look at it is, was the activation appropriate at the time of the call? We do not let results or the old ECG affect the accuracy counts. And if I could unpack that a little bit, or at least what I think Micah is saying, in the field, maybe you don't activate the cardiac cath lab, but by arrival in the hospital, the diagnosis is more obvious because, like Tim said, you do serial ECGs, and now what just looked like kind of a quirky T wave there in lead AVL is now, now it's dome-shaped and it's more obvious, or now it meets criteria. Well, why didn't they call that in the field? Well, it wasn't the same ECG, okay? Conversely, it could be a STEMI in the field, meet criteria, and then it's kind of cleaned up by arrival in the emergency department. So they kind of slow things down, and maybe then there's no clear culprit artery. And so, did they do the right thing with the information they had available at the time that they made the decision is the only fair way to judge any decision. Forget STEMI. It's the only fair way to judge any human being's decision in any complex system is, did they do the right thing with the information that they had available at the time? So that part's interesting, but I think from a measurement standpoint, it's still worthwhile to see how many patients received an ECG, how many of them had symptoms, how many of them met criteria, how many of them were cathed, how many of them had a culprit artery. I think all that stuff kind of goes into medical academic research, and it helps us do apples to apples comparisons. So, Mick, what can we do, or what is the ACC doing, or what are you doing in all of your work? You must be doing something to help us standardize all this, and so that we can do better comparisons, apples to apples, between my EMS system and someone else's.
Yeah, so the work on a standardized definition is where I've been putting a lot of my time and effort. Initially, when I was working at the ACC as the clinical systems director there, was part of that PREACT project and was one of the authors on that paper. I saw that as kind of an initial step. But in the conversations with my co-authors about this topic, one of the things we were really spending a lot of time on was exactly the issue you made reference to, is basically following the protocol. Did that meet the criteria at the time they made the decision? And what I think the opportunity for improvement there is, instead of having that be a completely subjective sort of thing, having a very, hard and fast list of criteria or parameters that must have been met at the time to guide that decision. And it might be more of like a scoring system, or all the boxes need to be checked to meet the criteria. But again, from a measurement standpoint, even if it isn't perfect, if we're doing it consistently and it is reasonably close in terms of meeting the actual absolute criteria, then at least we can move forward. And again, it might not be 100% accurate in identifying every case that might have been caused differently. But if the medical director and the clinical manager in the design of their process, the design of their activation protocol, establish these things must be present and these factors must be taken into consideration, if that is somehow captured in the documentation, then over time we can look back on those and say, you know, which one of those things really seem to be associated with ones that truly turned out to have a culprit vessel lesion and which ones didn't. Was it some variation in the amount of ST elevation? Was it age parameters? Was it, you know, other comorbidities? There's all sorts of factors that might contribute to that decision one way or the other. And so that's where I think there's an opportunity for us to try to move this forward. And then, you know, make sure that our data collection processes allow us to capture that information so we can measure it. Because my frustration as an improvement scientist, if you will, is that we don't have all of the data captured that we need in order to analyze this problem to the extent that's appropriate. And so even if it's just during a research study period, if we can maybe put a little bit more emphasis on some of those other factors that go into the decision and figure out how well our process is working and adjust it accordingly, I think that would be helpful. And have, you know, several places around the country do this, because we never have one study, you know, really win the day. If multiple people coming at this with similar approaches all come to the same conclusion, that's where we meet the test for level of evidence and have an evidence-based process for defining overcalls and undercalls.
Well, Mick, do we have time for one more question from the audience?
Sure. Let's take a shot.
All right, this was from William Schneiderman, and here was the question. So, what are your thoughts about a pre-hospital encounter where a 60 to 65-year-old male with a history of cardiovascular disease, clean ECG, looks like ACS with the appearance of an impending STEMI, clearly not a STEMI activation, but an ACS notification with 12 leads transmitted? So, and Tom, please, you know, throw your 2 cents in when I'm done here. So, wow, you talk about situations dictating procedures here. There's just so many variables on this. Just a couple of considerations, you know, is like, one is, as a reminder, I mean, non-STEMIs are real. Non-STEMIs will kill you. Non-STEMIs are acute. Non-STEMIs have a clot. But non-STEMIs may not need immediate reperfusion, and so they may be responding best to medical management at the closest emergency department, and then potentially go to the cath lab 24 or 48 hours later, or whatever. So there's a part of us that probably always wants to advocate for the patient and do the best thing for them, but sometimes going to the cath lab isn't the best thing for them. So there's that piece of it, but kind of in between STEMIs and non-STEMIs, or what people sometimes call STEMI equivalents. Sometimes they call them semi-STEMIs. You know, if here's my shortcut for it. It's a really bad clot in a really bad spot, but it's not 100%. So they don't have ST elevation. So it's not technically going to hit the guidelines, but because it's a really bad clot in a really bad spot, unlike the rest of non-STEMIs, they would respond favorably to immediate reperfusion. So that's a whole nother consideration into here. Serial ECGs would play a role, your system design. Are you going to that hospital with a cath lab anyway, or would you be transporting to a different facility? And so there's a whole lot of variables. I don't feel like I could even begin to tell you what the right thing to do is on that particular call. But Tom, what are your thoughts? What would you add into that?
Well, my thought is I hope that the efforts that are being made with machine learning will help it so that our computers all get as brilliant as Stephen Smith at identifying occlusion myocardial infarction in situations where the patients don't meet the millimeter criteria, which in the last analysis are pretty arbitrary, especially if we're saying we're expecting those criteria to be met, say, in the high lateral leads or something like that. So this is where the rubber meets the road. And I think these decisions have to be individualized a little bit at the system level. What I worry about it is when these conversations aren't taking place with the right stakeholders. And so I would say the medical control physician of the EMS system and the director of emergency medicine and the director of cardiology, maybe both at the local receiving hospital and the STEMI receiving hospital, should be having a meeting to decide who makes these decisions about whether or not we do a Hail Mary pass all the way to the PCI hospital. Because there's pre-hospital activation, and that's one thing. But we all know that sometimes transfer STEMI, it's like it's been compared to getting stuck in a net. Sometimes you can end up at a hospital that doesn't do PCI. You may not get reperfusion at all, or your reperfusion may be delayed for hours. Because if you're in a rural setting and it's the middle of the night and the emergency department is being covered by a family practice physician who's a very good physician, but maybe not that experienced with ECG interpretation, at least identifying STEMI because they only see a handful a year, they may want to fax that, isn't that wonderful technology, to the tertiary care center. And maybe that person's not readily available. So all that's like tick, 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 tick. And it's not always that easy to get an ambulance either. And so these are complicated things. And I think you have to look at all of it. What is this hospital's capability? What is the availability of ground and air transport? And so I think all of these things kind of have to be contextualized and individualized to that healthcare system. I think what's important is to get the right stakeholders in the room together so that they can kind of build their STEMI system that works for their community, maybe even with community input. Because when we built these systems of care on Hilton Head Island, we've even got pictures of some of our early meetings, and it's easy to look at and be like, look, that's the first time that EMS and nursing and emergency medicine and critical care medicine and cardiology sat around the table. You know who was missing? The patient. So we actually have a citizen and patient representative now that attends some of these meetings just to bring that perspective to the table. And I think that can be really, really helpful so that things don't devolve into a turf war or something like that, because it's our patient representative happens to be a STEMI cardiac arrest survivor. So that's a powerful ally to bring into a meeting if you're having a roadblock.
Indeed. Well, it looks like we're starting to run out of time here. If any of you would like to get more information about ACC products and services for EMS and systems of care, check it out at acc.org/eReportsEMS. CSI products, including the new EMS Quality Academy, check out emsqualityacademy.com. And I would really like to express my appreciation for having both Tom and Tim join us today and bring their expertise and insights into the discussion. Anyone wanting to contact Tim can do so through his website at ecgsolutions.com or send an email to tphalen@mac.com as seen on your screen. Similar for Tom, he's at Tom B at Hilton Head Island sc.gov, and you can also find him on Twitter and LinkedIn at the addresses shown on your screen. So on behalf of the American College of Cardiology and the Center for Systems Improvement, I'd really like to thank everyone for attending today's webinar. Please share the links to the archive version of this webinar and the other webinars with your colleagues, and that will conclude today's presentation. Thank you so much.